Yeah. So, hello everyone. Good afternoon. I'm Dr. Shamsundar Raitata. I welcome you all to this session of exchanges in primary care, or as we call it as EPC. It is an informal series of sessions which we hold every fortnightly, twice in a month, where people who are working in primary care, who have done some interesting work in primary care, come together and share their experiences or share things which they think are new or which they want to want to share with people. And there is a lot of discussion which happens in a very informal setting. So today we have a group of speakers from diverse backgrounds would come together and talk about the impact, public health impact of the conflict which is going on in the West Asia region. This session has been organized or brought together by alumni of Community Medicine Department of CMC Vellore who are in different places, and they have been very instrumental in bringing the speakers and planning this session. So without wasting much time, I'll hand over the session to Dr. Swathi to take it ahead and to help us understand this session. Yeah, over to you, Swathi.
Thank you, Dr. Shyam. Good afternoon, everyone. Thank you for joining us. So, on February 28th, as many of you know, coordinated Israeli and US airstrikes hit Tehran and several other Iranian cities. This wasn't an isolated event, it followed the intense 12-day war which we saw. Hostility spilled into the Gulf, shipping through the Strait of Hormuz was disrupted, and oil prices spiked. It was a blunt reminder in our modern world no conflict really stays regional for long. We often talk about war in terms of strikes and targets, but as public health professionals, we look at the people. Those numbers are horrifying, but we also know that in public health, the invisible toll is often the heaviest. You might be wondering, how does this hit home for us in India? Modern warfare doesn't just break buildings, it breaks systems. Even if we don't see the smoke from our windows, we feel it in our pockets and our programs. It shows up in the rising cost of energy and shipping. It is in the price of medicines we import, the food on our tables, and the fertilizers our farmers depend upon. Every time the price of oil jumps, the fiscal space for India's public health and social protection shrinks. Today, we want to trace those dominoes. How does a conflict in the Middle East end up affecting a mother in the forests of Chhattisgarh? How does it impact a family in a Mumbai chawl or even a household in Gurgaon? It's a chain of events that starts with a drone strike thousands of miles away and ends in the everyday lives of the most vulnerable Indians. As a public health community, we can't just be spectators. We have to respond with clarity. But before we can act, we have to understand. We need to map out exactly where and how these impacts will show up so that we can protect those who are more at risk. Before we bring in our expert panel to help us map these dominoes, let us take a look at the results of the survey, which many of you had taken part in. Your responses are giving us a pulse of what this community is most concerned about. So let me just share my screen for the poll results. If somebody could tell me if my screen is visible.
It's
Yes,
visible,
it is
Swati.
visible.
Yeah, thank you. So the survey results. Sorry, the screen froze. Um, Let me try resharing it. Is this okay?
Yes,
Yes.
but it's
You
not
can
in
make it
slide
full
mode.
screen.
Yeah. When I'm making it full screen, the slides are not changing. So
Okay.
I'll have to manage with this. So we had a question, a mix of structured questions as well as open-ended questions in the survey. So our first question was to rank the war effect, whether the respondent thought that war and conflicts affect health as a whole. So our respondents, out of our respondents, 86% of them felt felt that wars definitely have a huge impact on health, and they gave it a score of 5, whereas 14% thought slightly less impact, as in score 4 was given. But all of them thought that wars definitely have an impact on health. The next question we asked was whether if they thought wars impact health, then how was it? Or if they thought no, how was it? All of them thought wars do impact health. So 57% of the respondents gave a descriptive answer, and they thought of the implications in through different pathways. Uh, some of them thought that collapse of health infrastructure, including clinical services, sanitation network disruption. All these will lead to disease outbreaks, and not only communicable diseases, but mental health issues can also be at scale. Another pathway which they thought of was trade disruption and supply chain getting disturbed, and that leading to shortage of essential commodities, including medicines. The other pathway was trauma and mass displacement of individuals, especially vulnerable groups getting affected and leading to a huge humanitarian crisis. The next pathway which they thought of was, of course, the economic impact, more funds being diverted for the war, and other critical portfolios receiving less attention or priority from the government. The next question which we asked was whether, what were the broad areas which they thought were affected by the war, like broad areas of health. So 100% of the respondents agreed that clinical services, livelihood of people, and availability of foodstuffs, these were affected. So this was a structured question. We had given the options. So 100% of the respondents agreed to disruption of these particular domains, but only 85% thought about availability of medicines and medical consumables being affected, agricultural production being affected, and water, sanitation, and hygiene measures being affected. And we ask them an open-ended question on any other areas which they can think of which could be impacted by wars, and 43% of them responded with a descriptive answer. So the other pathways which they thought, or other domains which they thought would be impacted, was the disruption of agricultural systems and local food cultures, leading to a generational dependency on emergency aid and fundamentally altering a population's nutritional life cycle. They also mentioned about stripping away of community identity by erosion of civil structures and destruction of historical archives through war. Then, of course, there was mention of environment disruption and collapse of governance and administrative systems. Then we had asked about the tracing the pathways. This was again a structured question which we had asked. So here 100% of the participants thought of global trade disruption and shortage of medicines and consumables as one pathway, and also industrial production impacted and shortage of essential goods. 100% of the respondents thought of this as one of the major pathways. Then 86% of the respondents chose the response of subsidies being cut down due to war spending. 71% thought about fertilizer equipment production being impacted, and this leading to agricultural production decline and threat to food security, and also loss of jobs leading to poverty. So these were the pathways which they thought of. And we asked about an open-ended question about whether any other route was thought of. And 43% people gave a descriptive answer. They thought about lockdowns, bunker situations that could impact accessibility, misinformation spread, mass displacement of population, and a shift in state priorities. Our final question was on how could governments mitigate these detrimental effects, and all of them gave descriptive answers for this. So the major theme that emerged out of all their responses was strengthening the health systems through various methods, especially by decentralizing medical stockpiles, securing critical supply chains, and safeguarding essential infrastructure like water and sanitation grids. They also spoke about robust disaster management evacuation protocols, local community self-sufficiency, local resource sharing networks, diplomatic measures to maintain ceasefires and prevent wars, and discouraging war profiteering. So these were the results of our survey. This essentially gives us an idea about what our audience thought of regarding this topic. So I guess my screen sharing is off now.
Yes.
Yeah. So before we move on to the discussion, let me introduce briefly our each speaker. We have an eminent panel for today. Dr. Neeta Rao is a public health professional with expertise in public health financing and health system strengthening and has led the USAID India's health office for 14 years. We have Dr. Reji K. Joseph, a policy researcher and associate professor at Institute for Studies in Industrial Development, Delhi, with an extensive experience in research and policy analysis, particularly in the areas of the Indian pharmaceutical industry, trade and investment policy, and patents and development. We have Dr. Avinash Kishore, a senior research fellow at International Food Policy Research Institute, South Asia. He works around understanding food systems, agricultural practices, and agriculture nutrition linkages in the South Asian countries, including India. We have Dr. Ramani Atkuri, a public health physician who chose to work for rural development among the marginalized communities with organizations like UNICEF, Jan Swasthya Sahyog, Basic Health Services, to name a few. We also have a special guest of honor, Dr. Manohar Agnani, who is a public health professional and retired IAS officer, former Additional Secretary of Ministry of Health and Family Welfare, Government of India, and currently faculty at Azim Premji University, Bhopal. So these are our speakers for today, and today's session will be moderated by Dr. Suranjeen, who is Director of Programs and Strategies at JHPEIGO. He's also an alumnus of CMC Vellore Community Health Department. Over to you, Dr. Suranjeen.
Thanks, Swathi. It's been almost over 60 days, I think much more, since the first strike hit Iran. And, it's almost, we've sort of, the early days were very tense. I also had relatives in the Dubai area, and we were constantly getting feedback. But today, other distractions have taken that space. The elections came in, the results came out, who's going to, take which party, or maybe other distractions at workplace or anywhere came in. And somehow the war, the conflict, the West Asian conflict, just seems to is not catching our attention. But I think today what we're going to ask is this really true? Is this going to be something like a slow bleed that will continue to affect us? Or do you think we are now seeing the worst and we are only going to get better? And, just before I bring in the panelists, I was just thinking of the song I grew up with, Civil War, sung by Guns N' Roses. It says, I don't need your civil war. It feeds the rich while it buries the poor. And much earlier, Black Sabbath, a favorite group of mine, sang from a song called War Pigs. Politicians hide themselves away. They only started the war. Why should they go out to fight? They leave that role to the poor. Thank you, Swathi, for that introduction and for giving us a glimpse of what the audience is thinking, through the poll. We are truly delighted to welcome our 4 distinguished panelists today, and they're all from very diverse fields, as you can see. And the way we will be organizing is each of them will get 5 to 6 minutes to put their points across, and then we'll have a discussion. And I really would like audience to start asking questions in the chat, and then I'll be asking audience, either we'll be reading out the chats or we'll be asking audiences to, come in and share their questions, and would like to have a discussion. Before we have Dr. Manohar Agnani close this. He has still not yet joined, but he should be joining in soon. For the speakers, for the panelists, I would just ask you, while you're speaking, just also talk about one key risk to India, that could arise out of this West Asian conflict. And also if there's one protective measure, that we should be, keeping in mind that could help reduce this impact. I'd like to request our first speaker, Dr. Neeta Rao, to go ahead and start speaking, and she will discuss about how war and conflict, impact or affect our fiscal space, and in turn, how they would help shape health financing decisions. Dr. Neeta Rao.
Thank you, Dr. Suranjeen. I have a couple of slides. Dr. Swathi, will you be projecting them or should I share it?
I haven't received it, ma'am, on mail.
Oh,
so you can share the screen.
Sure.
Suranjeen, you're sharing it, is it?
No, if I understood right, Dr. Neeta herself will share it. Am I right, Dr. Neeta?
Yeah. Yes, it has come.
You're able to see the slide, right?
Yes.
Yes, ma'am. Yes.
Yeah.
If you could go into the slides sharing mode, if that's possible.
Let me try that. Is it working?
Yes, it did.
Yeah.
Okay, great. So as Dr. Suranjeen said, it's actually real. Even everyday newspaper actually is talking about inflation, the possible rise in fuel charges. So, and this presentation, I want to just highlight that we still don't have any changes reflecting in the budget allocation or even in terms of prioritization by the government. But we'll be using the past data to sort of have a discussion on what are the possible impact of this war on the health financing, on the public health financing and overall health financing space. So to begin with, I just wanted to share the baseline where we stand, which is the starting point. So India, as it is, spends relatively less as compared to other countries on health, which is just about 1.8 to 1.9% of the GDP. And the National Health Policy of 2017 actually talks about a target of 2.5% of GDP on health that needs to be allocated. So if we really look at the difference between the target and the actual allocation, it is to a tune of 2.5 lakh crore rupees, which is additional that needs to come into health. Also, if we look at the trends over a period of time, the allocations seem to have increased over a period of time with 11% growth rate in health allocations. However, if we look at the overall proportion of allocation for health versus the total government expenditure, it's relatively low. Even at the state level, there is a target of about 8% that needs to be spent on health, but it's for most of the states, even the progressive ones, it's less than 6%. If we look at National Health Mission budgets, which support all the vertical programs, all the national health programs, at 33,000 to 38,000 crore rupees, it has remained relatively stable over a period of time. However, the standing committee report actually clearly states that it's under allocated. And given that the National Health Mission covers so many programs, it's expanding. There are so many new programs that have been introduced. It really needs to be backed with good funding, which is not happening. So what does all of this mean? It actually translates into high out-of-pocket spending for the population, which is to the tune of 39% to 45%. You'll see the difference here because 45% is out of the current current health expenditure and not the total health expenditure. It's about 40% or 39% of the total health expenditure. And this actually gets reflected with distress financing. So when people get hospitalized, especially from the low socioeconomic group, they tend to borrow or sell assets, which is around 17%. And a lot of people, roughly about 6 to 7% of the population, get pushed below poverty line just because of healthcare expenditure. So what happens when the baseline itself is so low? It actually shows that, when there will be an external shock, there will not be much of a capacity for a low risk resource system to be able to take that shock. And it will therefore hit the system further and hit the most poor and vulnerable population hardest. And why does this happen? Because, the government needs to prioritize across different sectors, and health really doesn't come there. So in terms of fiscal transmission or fiscal stress, how does that transmit from an external conflict situation to the public financing? If you look at large ministries or departments or thematic areas, there are about 50 to 60 where the government has to make allocations. So if you look at the topmost 16, it contributes to about 64% of the government's allocation. And out of those 16, health is 11th. So that really talks to the prioritization that health has. And as we all know, that defense is the one that takes the topmost priority, and understandably so. And in conflict-like situation, it will take further priority. That is something that we need to keep in mind. Right now, the allocation for defense is roughly about 2 to 3% of the GDP. And, if you look at the trend, the growth rate in the allocation for defense has been 15 to 20%. And obviously, it's going to grow in this kind of a conflict situation. And there are studies to show that, especially the recent Lancet series showed that 1% increase in the military spending actually brings about a cut of 0.62% on public health financing. And in low income countries, it's further steep. It's 0.96% of the public health financing that gets reduced. So what it means is every rupee that goes for military expenses, a rupee is not getting allocated for health. We all know that the global external aid has been reducing, and recently the WHO in 2025 quoted that there is a 30 to 40% reduction in the external aid. USAID funding cuts itself has impacted tuberculosis, HIV, and malaria program through just the Global Fund channel. And I think the survey itself has shown from the participants has shown that you are very aware of how it is going to disrupt the supply chain and how it is going to impact the healthcare sector itself. So if we look at India is being the pioneer and the major supplier of generic medicines, but we also need raw materials to produce those generic medicines, right? And 60 to 75% of that is imported, largely from China and some from Europe. So obviously that means that the whole manufacturing gets impacted. And if you look at medical devices, 70 to 85% is imported from other countries, largely from Netherlands, Germany, UK, and many other countries. And if we look at the advanced class C kind of devices, which are required for imaging, for higher level of treatment, like for cancer, they are almost like 80 to 90% that gets imported from other countries for India. So obviously, when there is a supply chain issue, there will be an impact on, the production cycles, on inventories, and all of this is going to translate into affordability and availability of these drugs and devices for the end users, for the population. And programs such as RMNCHA, tuberculosis, immunization, NCD programs, these are highly vulnerable in this kind of situation, not because they get targeted, but because they highly depend on, continuous operational expenses, state releases under NHM, on the frontline services and the incentives that are paid to the frontline health workers, on medicines. So if all of this gets impacted, and these are the ones that are highly vulnerable in conflict situation, and therefore all of these programs tend to get first impacted. Also, going back to the survey, I think I don't have to explain the content in the blue box, like, how it affects the conflict effects, energy prices, and all of it. But one thing I want to draw your attention is also when the energy prices goes up, the hospital expenditure, the facility expenditure, the outreach expenditure, everything increases because, we need electricity, we need, cold chain that needs to be managed. Then the patients need to reach to the hospital. So if their fuel charges go up, they actually delay health seeking. So there is a lot of other impact that's happening because of the volatility in the oil prices or the fuel prices, and also in terms of remittance. Like Dr. Suranjeen mentioned that he has a lot of relatives, and we know that there is a huge population of the Indian origin staying in West Asia. And there's a huge amount of remittance that comes from their earnings, and it constitutes roughly about 36% of the total remittances. So obviously those families then get affected, and again, it goes into a vicious cycle. So ultimately, what happens when, all of this, either in form of direct impact or indirect impact, influences health and health outcomes? It's basically the most vulnerable and the poor, the marginalized who get impacted. This is the data that I've picked up from NFHS, NSSO, and NHA, which clearly talks about, the difference in health seeking behavior among the upper income quintiles versus the lower income quintiles. So obviously in India, there is a tendency to seek services largely from the private sector still. But still, if you look at the lower income quintiles, they fairly access the public healthcare system. And that's not because they have confidence in the system, but it's because, they do not have the ability to pay for healthcare services. Thankfully, over a period of time, the coverage of insurance has increased, and this is largely attributable to PMJY and the state government health insurance programs, which have been merged with PMJY. And, there's been a remarkable increase from about 11% for the lowest income quintiles to 32% of their coverage. But the challenge is that this covers only for hospitalization. And as I mentioned earlier, if prices go up, if the health system delivery gets impacted because of financial constraints, it's again going to impact the hospitalization. But what is critical during a conflict situation is the frontline or the primary healthcare service, which is like the foundational to health system. Catastrophic expenditure is high among the poorest, and therefore, people who can afford, they have little more discretionary spending ability. And overall, what I want to sort of emphasize here is that, as Dr. Suranjeen mentioned, that this is a time where there is a slow impact on the health system. And therefore, we actually need to ensure that our health system is getting ready and becoming resilient to handle the stress over a period of time. We still have time to work and prepare for it. And we don't know when it's going to hit us in what way. The private healthcare, if we leave it to the private healthcare system, costs are going to increase, but they're also regressive because they do not differentiate between how much one can afford to pay. Like the cost of drugs and diagnosis is going to be the same for everyone, irrespective of the ability to pay. So I'll just stop there. Thank you.
Thanks, Neeta. I think that was a very, wide overview, and you were mentioning about, if these budgets tighten, you were talking about TB, infectious disease, RMNCHU could get affected over and above, what other, things happened, like the whole USAID collapse and funds coming through GFATM. So which one do you think, we should be as a country ring fencing within the public health function? Which one public health function do you think will be most critically impacted and we should be thinking about? as a public health community?
So, I mean, it's very difficult to prioritize because, the overall health system is critical, everything needs to be safeguarded. But again, we have these difficult choices to make when there is a constraint, right? So, if I have to answer in terms of one public health function, I would suggest disease surveillance and early outbreak detection, because that's the backbone of health security. So it includes routine surveillance systems, lab networks, reporting systems, field epidemiology, and rapid response teams. And it must be protected because, if it gets delayed, if you delay the detection, it leads to large outbreaks and high number of mortality. And early response is far cheaper than actually doing a crisis management. And we have seen that during COVID pandemic. And most importantly, it protects both health systems and the economy, if we have to look at it from a broader point of view.
Yes, COVID-19, taught us the importance of surveillance and also gave us the impetus to, set up surveillance systems. And I think that's something we've seen really grow and become strong in the last 3-4 years. And that's something we need to, move in. Our next speaker is Dr. Avinash Kishore, and he will be speaking about how conflicts affects, the food market, especially through fertilizers and other things. And he'll be talking about food security and diets. Dr. Avinash.
Thank you. Thanks a lot. So this crisis, the first thing is a partial good news, is not as bad globally and even in India as the Ukraine war was, or 2008 food price crisis. In this century, we have seen 3 big food price crises. One was in 2007-8, around that. Another was 11-12. And then a third one most recently when Ukraine was invaded. If you compare, the situation is somewhat better right now because global food stocks are decent right now, though they are coming under pressure as as petroleum prices are increasing. Some of the food is being diverted to turn into oil or fuel. So there is some pressure there. The demand, there isn't a big demand shock. One of these crises, there was a big demand shock as China was coming out of SARS and similarly. So the demand looks okay. It's not rising except for some demand for fuel. The supply is comfortable, except there's slightly tightening situation for maize and a little bit for edible oil. That's there. The third is the dollar is not weak. Normally what happens when dollar goes weak against world currencies, then commodity prices across the board, food and non-food, those start going up. Right now, dollar is not weak, dollar is strong. So broadly, so far, we are somewhat better globally and in India. If we look at India too, we are quite comfortable with rice and wheat. We have excessive stock in buffer, and that should come handy. Where we may have challenges, like I said, edible oil prices are going up. We are big importers. So world prices are increasing and rupee is becoming weaker than dollar. So import cost will increase. The same may happen with pulses. We do import a fair amount of pulse, and pulses price may also go up. In pulses, there is no scope because in edible oil, what government can do is reduce the import duty to absorb some of the shock. In pulses, the duty is almost close to zero, except yellow peas that comes from Canada. So there isn't a lot of scope. If India's production goes down, then there may be a shock. One problem that we are facing is there is this forecast that this is a super El Nino, once in a century type thing. If that creates drought too, then we don't know exactly how bad the drought would be. Broadly, in last 5-7 years, even 10 years, droughts haven't led to massive impact. India's food production has become resilient, more resilient than it used to be, though it's very hard to compare one drought versus other. The nature of the drought, where it occurs, etc., would matter. If drought happens, Punjab and Haryana won't get affected. Jharkhand, severely affected, whether you are irrigated or not. So farmer incomes may go down, even if production doesn't go down. So you won't have calorie crisis in India. That's my sense. but you may have income crisis in rural areas if drought is bad and if food prices start going up. So far, food price inflation is inching up in India, but it is still fairly low. And it's inching up due to fruits, vegetables prices, not the broad sources of calorie. Okay. So if the crisis resolves in the next few weeks, months, who knows? I think we'll get out of it okay, not that bruised. If it goes on and on, which sometimes seems to be a case, then winter season crops will be affected. We somehow managed to scrape through urea. We have only a small deficit, etc. But winter season will be in trouble. My biggest fear is because in India, government is absorbing all the rising costs. Fertilizer prices haven't risen in India, unlike, let's say, in Pakistan or even Bangladesh, etc. Similarly, diesel prices also and petrol prices so far, maybe due to elections, etc. The taxpayer is absorbing all the shocks, right? So something got to give in. If fiscal deficit increases, as Neeta was also indicating, then it may lead to inflation. And inflation may not happen right away. It may happen next year. So even if the crisis ends this year, you may see residual impact next year. If there's big fiscal deficit, two things may happen. One, Neeta already alluded to, is that you may cut back or tighten the expenditure on health, or the same nominal amount means less in real terms, right? That could be one impact. The second is large fiscal deficits often lead to general inflation. If general inflation is high, people's purchasing power may go down. Purchasing power goes down, all discretionary expenditure goes down, right? So people will eat rice, will eat wheat, the staples will probably hold, but healthier foods, health expenditure, especially preventive health expenditure, education. This is how, especially for poor households and particularly for women and girls, but even boys, you have long tail of crisis. The crisis for you and I, we won't even feel it if things become normal, except maybe at gas pump. But the poor people, if you take a kid out of school, if you didn't give the vaccination, if it is a paid vaccination, etc., or basic health care to a pregnant woman, etc., if those things don't happen, I come from Bihar, public health system are weaker there, let's say in Tamil Nadu, than in Tamil Nadu, then I worry that it may have a long tail. So just to answer the two questions that you posed, Suranjeen, I think my biggest worry is inflation. My biggest worry is if the crisis goes too long. I don't even know how we'll deal with it. But within what is in our control, if inflation goes up because there's only up to a point that government can go on absorbing the cost, that's my biggest worry. And my ring fencing thing would be, again, this is informed by where I grew up, is it's very hard to improve system in a short while. You need to make long-term investment in creating health systems, surveillance systems. So in well-functioning states or better functioning states of India probably will be okay. We should not cut back expenses on safety nets. This includes health safety nets, but other income transfer, etc. There would be an instinct to cut back or delay those. I think people's income, net income, real income shouldn't suffer. If that suffers, then you need to provide some cushion for the poorest of the poor. And within households, the one thing that we don't have good data on, with this I'll end the point, is we have data up to households, right? We have very little data on what happens within households. In South Asia, rough estimate is half the poor people live in non-poor households, right? Because if you look at individual consumption, the household may not be poor, but the woman, the girl, etc. may be. So how do we protect them in basic human capital expenditures, preventive expenditures? That's something that we need to figure out ways to ring fence in better functioning states, but also in like Bimaru states, Northeast, etc. I'll stop here. Thank you. I'm happy to answer any questions on this.
Yes, and if you have any questions, please type it in the chat, and then we'll also open up soon after all the four speakers come in. Avinash has largely been optimistic, about things. He feels that, we do have a strong foundation to build on, even though, we are also talking about the potential of drought, the potential of heat stress, and multiple other things coming in, including the war. But we also know that the bottom quintile, is very sensitive, and we also seen that when prices go up and inflation goes up, proteins are just not accessible anymore. We know that oil and other things become inaccessible, though, carbs, as you said, the cereals are available. And we know that definitely impacts health. I think nutrition is one of the most important determinant, for health. So from a health perspective, Avinash, if we are looking at, and trying to understand when we are actually tilting over, you know, um, what should we be looking as public health, as a public health community? Should we be looking at food prices? Should we be looking at our community and seeing when are they, shifting foods, or, swapping foods? Or should we wait till we start seeing children who are wasted? I mean, I wanted to know, where do we start getting anxious and worried?
So I'm not a public health expert, but I have 2 points to make. Is it's important not to look at averages. Even when the average condition in India is fine, like if you're a tribal household in Jharkhand or Chhattisgarh or even parts of Bihar, so it's important to go. That's why I was emphasizing like within household, but even in the regions, like especially poor regions, rain-fed regions. I think those are the regions that we should, and a lot of people here in the room who have dedicated their lives to work with them. That's where the condition should be flagged, because otherwise the news headlines in English or even in local language would be, oh, we are sitting over the huge buffer stock and government is transferring more grains through PDS, etc. But I think that's where we should be looking at 2 points. One is general food price inflation, which may not go up by a whole lot. We have been comfortable so far. And the second is income crisis, in the sense that if you're in the field and you're sensing fewer jobs, because if economy slows down and other those macroeconomic impact, if we're seeing generally that people are spending less on things that they used to spend, I think what Arundhati Roy would say, listening to the grasshoppers, it's very, very important to listening to grasshoppers and relaying it, writing up it in the media, flagging those issues so that we don't get carried away by general good news, which is what we tend to do these days. So I would say that that is an action to do. Children wasting may take a while, though I'm not an expert, so not sure exactly when that happens. I'm not expecting people to skip meals in India. That would be on the margins only, if at all. Those margins matter. It would be the diet quality may go down if the incomes go down, etc. That's something also to keep track.
Thanks. We now have Dr. Reji Joseph, who will discuss how conflicts impact global trade, logistics, especially, leading to access to medicine.
Thank you, Suranjeen and Swathi, for inviting me to this forum. I am very glad to participate. Let me share my views. Actually, no one knows when the conflict in West Asia is going to end. Even the Trump who initiated the war, he doesn't have any idea. The US is saying we have ended the stop the offensive attack, but Iran is saying no, there has no end. So nobody knows what is going to happen. But one thing we all know, that the tension is continuing there. If the tension continues for some more time, then it will start manifesting even in the public health of India. This is because medicines is integral part of public health, and we are dependent on inputs coming out from the crude oil purification process. So the petrochemicals are inputs for pharmaceutical products production, especially those are based out of synthesis. And this crisis is also leading to increase in transportation costs. As a result, it is going to impact access to medicines, both in terms of availability and affordability. So I will explain how this is going to impact. If you look at the pharmaceutical input prices in the past few weeks, what we see is that, for example, paracetamol API, its price has almost doubled in 2 weeks' time. Similarly, glycerin, ciprofloxacin, and as Neeta was saying, we are majorly dependent on China for APIs. The average price of APIs from China has increased 30-35% in the past few weeks. Similarly, the container freight charges from China, it was almost double. So this is how the expenses are going up. But the formulation, the finished tablets that patients consume, the price of which hasn't gone up because we have the national pricing, pharmaceutical pricing authority. So they regulate the price of medicines. So because of that the drug price control order and price capping, the cost of medicines have not gone up. But the situation is such that it is like a pressure cooker on the stove. The pressure is mounting up, but beyond a point, the pressure will have to be released. When that time comes, it will be very difficult, and the price of medicines will have to increase. Now, the report suggests that molecules like paracetamol, amoxicillin, azithromycin, ciprofloxacin, metformin, ibuprofen, vitamins, and medicines used for cancer, hypertension, they are all under this price pressure. Can we move to next slide? Swathi,
So I'm just trying.
yeah.
Mhm. Can you see?
Yes. Yeah,
This
go to the
is
next.
yeah.
Yeah, go to the next slide.
Yeah.
So I said these petrochemical inputs are essential ingredients for pharmaceutical production. One example is ammonia. So ammonia is used for fertilizer as well as for the pharmaceutical production. In India, the annual requirement is about 70-90 million tons. Out of that, 90% is used by the fertilizer sector, remaining 10% mostly by the pharmaceutical sector, but by other chemical sectors also. Now, there is an issue with availability of ammonia, and we produce ammonia here, and we also import ammonia. From the ammonia that we import, Oman and Saudi Arabia, they account for 70%. Okay, so now the supply from the Middle East that is affected. So there is a crisis that we are facing in terms of availability of ammonia. And natural gas is a main feedstock used for the production of ammonia. And we all know that there is a issue that we face in terms of natural gas availability. So this is also adding to the crisis. Similarly, we import certain APIs. If you look at the total import portfolio, about 16% we import from Europe. So it is coming through European ports to Mediterranean Sea, then Suez Canal, then Red Sea, then Babel, Mandeb Strait, then Arabian Sea, and it's coming to the Indian West Coast. So since the Houthis attack on ships, this was slightly diverted from the Red Sea. It used to transit via Saudi Arabia to UAE, and then it used to cross the Hormuz Strait and reach Arabian Sea and then India. Now the entire disturbance in the region is affecting this supply route. So as a result, the APIs that we source from Europe, that is also getting affected. Now, it is reported that due to the scarcity of raw materials the pharmaceutical plants are facing, many plants in Gujarat, Maharashtra, Telangana, and Andhra Pradesh, they have partially or fully shut down. It is industry experts also warn that about 200 pharma units additionally, they could face shutdown in next 1-2 weeks time. And it is also reported that in the first quarter of this year, about more than 200 generic products were discontinued. So usually the pharmaceutical companies withdraw some brands, but this time the rate of withdrawal is much higher as compared to past years. So I think this is also related to the availability of inputs. Next one. So this is again the dependence on China. So we import more than 70% from China. The cost of all raw materials that import from China has increased. As I explained, the container freight charges increased more than double. Similarly, air cargo charges also increased about 400%. So this all will add up to increase in the cost of inputs. Next one. See, when resources are limited, the policymakers will have to assign priority. So there is, I think, a silent dilemma the policymakers are facing, whether to give priority to food or medicine. If we look at the natural gas supply regulation order issued in March, it has assigned priorities for different sectors. The first priority is domestic pipeline, natural gas and CNG. That is the top priority. Second one is fertilizer. Third one is industrial and commercial consumers, and pharma will come under the third category. Now, this order is saying that since fertilizer is in category 2, they will be given a higher priority for allocation of natural gas. So since there is a scarcity, this order is saying that given your past 6 months consumption, a 70% of that will be supplied with. Okay. So pharmaceutical sector is given a lower priority, so the supply will be even lesser for the pharmaceutical sector. And it also said that the natural gas used for the supplied for the fertilizer sector should be used only for the production of fertilizer. Okay, so usually what happens is that the fertilizer product manufacturing units, they also produce ammonia, and that ammonia is diverted to the pharmaceutical sector. Now it is saying that the fertilizer units which produce ammonia should not divert to any other sector, including pharmaceutical sector. So this has become a major issue. So Department of Pharmaceuticals took it up. It said that unless ammonia is applied to pharmaceutical sector, there is going to be a major public policy issue. Similarly, Pharmexil, the Pharmaceutical Export Promotion Council of India, it also said that a number of petrochemical inputs such as propylene, methanol, ammonia, butane, they are all essential for pharmaceutical production. Unless the supply of these inputs are ensured, the pharmaceutical production as well as export is going to be affected. Similarly, Ammonia Udyog Association has also taken up this issue with the Ministry of Fertilizers. Now, some good things are also happening. The government, from their side, they are also trying to reduce the price burden. One thing is that the basic customs duty of about 40 petrochemicals has been reduced to 0. So as a result, whatever imports coming, there won't be any custom duty. So similarly, as a follow-up of the pressure mounted by Department of Pharmaceutical, there is some increased supply of natural gas to the pharmaceutical sector. So I think that way we are able to manage for the time being. And as of now, we have API stock for about 2 months and the formulation stock for about 6 months. But if the tension continues for a few more months, then gradually we will face the implications manifesting in the public health sector in terms of increased drug prices and shortage of medicines. I will stop here.
No, thanks, Reji. I think you've been, showing multiple, reasons and pathways to, the potential increase in drug prices, from which way. And but you also mentioned that, probably APIs will be the most important reason why these drug prices will go, because that's a supply chain that brings them, either to make them or to convert them from within APIs to, drugs in India. We also know that, there is a provider linked incentive scheme that's been running by the government since 2021. Do you think that scheme, which was put in place in 2021, could actually cushion out anything? Do you think we would be having APIs directly made within India to, to sort of insulate ourselves?
See, the PLI scheme launched in 2021, so that had what to say, it aimed to address the import dependence on China. Okay, so during the COVID time, so the supplies from China were badly affected. So that time there was a committee to look into India's import dependence on China. So they identified about 42 APIs in which India was heavily dependent on China. So this PLI scheme mainly aims to address that import dependence on China. Out of the 42, I think about more than 20, the production is taking place in India. The firms are investing for additional capacities. But my guess is that, see, again, that is focused only on the APIs. So that is an ecosystem for APIs, like other inputs required for the API production, like the solvents and other petrochemical inputs. So this PLI scheme has not taken into consideration that ecosystem approach or all the other inputs required for the API production. So I think this is a real-time test for the effectiveness of the PLI scheme to see how, resilient it is to meet challenges like this. So I think this is a real-time test, and it will show whether we need to do anything additionally.
Thanks, Reji. Thanks a lot. We have with us now Dr. Ramani. She'll be speaking about, what breaks first at the last mile during crises, who tends to get excluded, what district authorities and communities can do immediately, to respond to this. Ramani.
Hi, Suranjeen. I've deviated a little bit from what you're expecting,
Sure.
but I've just put together my thoughts in a few slides. A lot of it has already been said by Neeta and Avinash and Reji. So, and excuse me, this is extremely colorful because I needed something to cheer myself up in the thing of all this gloom. Can you see it? Is it in full screen mode?
Yes, in full screen mode,
Yes,
but still black and white, Ramani.
Yes, this is black and white. Yeah. Okay. It's not moving.
Yeah, there seems to be some issue with slide share. So
Is it
just
moving
avoid.
now?
No, it's not
Let me
moving.
try and
Raman.
share it again. Let me try and
Try
share
share it without slide share.
it. Okay. Yeah, you can see it now.
Yes.
And now is it in slide share? Is it in full screen?
No, it's not, but I think let's avoid that. Can you go to the next slide?
Okay, let me, okay. Now is the next slide
Yes,
visible?
yes, yes.
Okay. So as has been said, we are already importing less petroleum than before. I think 16 or 20% less. We're heavily dependent on the Middle East for this. This is also on top of other wars and other tariffs imposed by the US. So it sort of narrows down where we can get our petrochemicals from. And in India, in urban India at least, the LPG crisis has driven many migrant workers back to the villages where there's no NREGA. And the new scheme has not yet started. So there is a reverse migration with very little income generation activities which are available. Farmers, especially in Punjab, and the reports have been from there, finding it difficult to get diesel for harvesting crops, not getting enough fertilizers. And then all this is on the background of an economy that is already not doing very well, high unemployment, and probably looking at a high inflation that's going to come in. And the health budget is already very, very poor. So if you look at the impact on health, depending on a whole lot of factors, food, water, the environment, health services, whether a person can access those services and health facilities or not. So we look at food and water, the fact that we are facing a super El Nino with probably a poor monsoon, drying of water sources, which also impacts the growing of food and our monsoon crops, with high fertilizer costs, high diesel costs, so very high input costs going on. We are dependent on 60% of our oil is imported, 20% of our pulses are imported. And then this will overall resulting in low food production plus the food costs of importing and the food transportation costs. So we are going to have less foods. I mean, maybe not rice and wheat, but the other things and more expensive food, all leading to food insecurity and a worsened nutritional status, especially for the poorer quintiles in the population. The other thing also about the thing is that not related to the war directly, but the climate change and El Nino and the heat island effect, especially for urban areas, and the thing, environment is hotter and drier. People who work outside and farm laborers who are exposed to, who work in the sun, heat exhaustion, heat stroke, and increased deaths leading from this. And what happens to the health services with you? We have already increased drug costs, probably reduced availability, drug stockouts possibly. And what happens to the health budget, we don't know. The prioritization is fertilizers and other things, as Reji has pointed out, including not only the drugs, but also the hospital supplies like syringes, IV tubings, everything, which would probably be scarce. And most of the government drug supplies, our contracts are from MSMEs, which don't have a big buffer to, to put in the money to have sustained production and keep sourcing supplies even if they're more expensive. So they are the ones who supply the primary health centers and, our government public health system. So availability there may be an issue before it affects other things. So I think we are looking not only at the crisis because of reduced availability of drugs, we are looking at availability and the increased cost of food and the effect of the El Nino or the super El Nino, which is expected this year. And so that's what I think is going to happen. And of course, proportionately, the people who have a lesser resilience to absorb these costs would suffer more. And I thought, as public health workers, what can we do? I think the possible effects are worsened hunger and nutritional status. What happens to vaccine production? I don't know. Will there be interruptions in supplies? And what happens then to the vaccine preventable diseases? Drugs and supplies stock out, more illnesses and treatment interruptions. If we have all these NCT drugs and all not being produced, or interruptions of medicine availability. There will also be increased cost of seeking care, even in terms of finding transport to reach a health facility and the cost of the transport. So delayed health seeking with more, coming to the facility in a more serious condition, increased costs of healthcare. And then what happens to the ICDS services? What happens to supplementary nutrition? It all depends on what the government does with the budgets and whether it continues to give the same amount of priority. As it is, there's a lot of exclusion because of digitization and a portion tracker and all those other things. But will the supplies even be there? In many areas, the services themselves are not running even now. But even in places where they are running, would they continue to run in this manner that they are? I thought, all of us, wherever we are in different parts of the country, I think documenting would be a good thing to keep track. I mean, what are the prices of the drugs in the market? one in Jan Aushadhalaya and one in a retail drugstore. How are they moving? Document stockouts. Whenever we find that the person has come back saying, "Wahan pe ye dawaiyan nahi hai," and what are the budgets for health and the various components? Now we'll have the New Year's budgets coming out. What's happening to the migration? Is there reverse migration happening? And what are they doing when they come back? Or is there out migration still from the areas where we work? And nutritional status of adults and children in the coming months. Is there food stress? And is there any change in patterns of illnesses seen? So I thought these were some of the things that one could look at and document and monitor. And to what end? I think for advocacy purposes, to see. We'll also have to see, I mean, this is all like everyone else has said, we are speculating that I think, even if the war stops today, there will still be some knock-on effects for some months. And then the El Nino is not going anywhere, it's going to be there. So that will still have an effect. So this is the scene as I look at it. I think there will be some interruptions in drug supplies. I think there'll be increasing food stress, mostly because of purchasing power of people. That's it.
Thanks, Ramani, and you brought together all the three speakers, quite well. I think you definitely talked about drugs and drug prices being impacted, and could that potentially impact our national programs? I think our largest national program that distributes drugs is the tuberculosis program, and we're really, not fully aware, how that will get impacted. Will PMJAY step up? And will they be able to actually get in as many, cover or be the safety net, for the really poor? And, will nutrition, impact largely the vulnerable and poor? We also know that it'll be the vulnerable groups. But more importantly, in India, we definitely have a lot of what we are calling in global health fragile ecosystems and fragile systems. We know that you've done work and advocated for work in both Manipur and Kashmir and other places. Would you want to just come in here to just tell us a little bit about how all these would put together and the impact, like some of these areas that we know could probably be the worst impacted, and what should be done?
I think in a conflict area like Manipur, things are a bit different because there is an active conflict going on. There's an ethnic conflict. Even pre-conflict, for instance, the systems in the hills were very, very poor in terms of infrastructure, in terms of human resource. But what the conflict has done has driven the people away, separated them. So the few doctors who were specialists in the hills have retreated to the valley. So there's a huge shortage of specialists. People used to go down to the valley for investigations like CAT scans and things. They don't have access to that, so they have to travel 12 hours to the next state and access care. So that has affected them in a totally different way. Also has involved a lot of displacement. I mean, living 3 years in a displacement camp has its own huge implications in terms of mental health issues. It has disrupted services, health services, ICDS services. So that is it's an infinitely worse situation if you're in an active conflict situation. I think someone has a question, Yogesh, I think.
Yes. Before we take Yogesh's question, I just want Avinash to come in. There was a running chat between Avinash and Vasundhara. Avinash, would you want to just come in and
my main point in response of Vasundhara raised this point that people's diet are already poor, which is totally true. Will there be famine-like situation? So my point was the diet quality may worsen from already where it is, but I don't think that there would be famines except in conflict zones, etc. I don't know about them, but I do not expect famines happening in India anytime soon. That's the limited point I was making. Yeah. Unless there's a follow-up or something, then I can come in again.
No, thanks. Yogesh ji, over to you.
Yeah. So if I may, I got a sense from the presentations which were very informative, but that it's largely up to the either we there's a sense of gloom and an impending doom that that seems to be pervasive in the entire presentations, but also I mean besides the optimism that Avinash sort of gave a glimpse of, but but um, but also the fact that it's possible. The expectation is that the My Baap Sarkar, which is not actually My Baap, no, it's actually it's a Lafangi Sarkar, Government of India, if I have talked about, or the state as a whole. Um, what is it that the civil society partners, whether it's I'm not talking about only NGOs, but people's movements, trade unions, and farmers groups or whoever should be thinking about mitigation steps, and those would be taking things in their hand. We know that we cannot expect resilient systems. No, we need resilient communities rather than So, for example, if what should be the cropping pattern that people should take in even the Kharif one? Forget about Rabi that might come later. Is there something that we can recommend or think about? Secondly, are we prepared for handling worsening tuberculosis rates in the how do organizations that I'm posing this as an indicative list, but something, or how should we be fiscally prudent about our own expenditure in at household levels, or even in at community levels. So some of those things would be was something that people need to put their heads together rather than expect just talk about macro events, which obviously is important, but just not focus on that. Over.
Well, thanks. What are the social nets you think the government should be thinking of and we should be advocating for? And what else should we be doing both as individuals and communities? Ramani, would you want to take this first? And I would ask anybody else in the audience. I just want to make this a conversation, just not restricted to the panelists, but very important questions, raised by Yogesh. And then others can come in. Yeah.
I think certainly the PDS, keep it up and maybe expand the range of what is available through the PDS subsidized grains. Ensure that all the programs which have food support, whether it is the ICDS or whether it's the Nikshay Poshan, all those don't falter. And as Yogesh said, yeah, what are the practical solutions on the ground? I think in the rural, yes, advice on the less water consuming crops, more resilient crops would be necessary. Urban areas are a little more tough. You saw what happened in Noida. The protest was turned into criminal cases against them and, all kinds of things. So the state is cracking down very harshly on any kind of even legitimate demands. So urban poor are worse off in that sense. There are options for having more, solutions to deal with this. That's how I see it. What happens if TB drugs are not available, or there's an interruption in supply, or the costs of, increased tremendously? That we'll have to see.
So I just want to supplement one point that Dr. Ranjini made. It's a fact that we saw even during COVID that urban poor suffered worse during COVID for two reasons. One is India's safety nets are very rural geared because traditionally poverty was overwhelmingly a rural phenomenon. Not true anymore. So you don't have Narega. PDS also has 50% coverage, not 75%. and many other schemes also don't work well. The second is in rural areas, there are social networks. So traditionally in developing societies, government provides some insurance or this kind of support, but community also insures each other when not everyone is battered by something. So it's a fact that at same income level, urban household is likely, we have done this analysis, is much less likely to get, let's say, PDS or other support compared to rural area, even though the cost of living is higher in urban areas. So that's a very important point that we often don't consider in that and needs to be flagged, that urban poor do not have that kind of social network because they're often immigrants or even the government safety nets.
Neeta, would you want to also weigh in here?
Sure, sure. It's a tough question because obviously we are talking about the most vulnerable populations and not putting any further strain on their pockets, right? But still, if we sort of look at safety nets, if we could have robust risk protection mechanisms, there are a lot of models, but they are fragmented, far and few. But is this a time, is this an opportunity to strengthen it where the risk is shared within the communities and also try and negotiate with insurance companies or reinsurance companies to sort of, provide a wider net of reinsurance protection to, large scale sort of insurance programs. Again, I'm not talking about hospitalization. I'm talking about holistic or comprehensive care that should be available to people. Like we have the Seva model, we have the Uplift model, which are all very small. But and the challenge of these models is scale. But can we sort of have multiple of these models which are steered by civil society groups? The other important thing is also to bring in efficiency. But the whole question is, how do we bring in that accountability with the government systems? So have more of efficiency at the decentralized level. It's desirable, it is possible, but then, how do we sort of interface with the government and make it happen? I think a lot of us work with government in different capacities. And I'm also aware that, even government is sort of taking cognizance of this. So can we work together towards that? Like, for example, looking at finance commission fund transfers, make it more efficient, focus more on the untied funds. And also a very important aspect is philanthropists. Can we get philanthropic capital more as a bridge financing mechanism to sort of, fill in some of these gaps and needs? And while on the other hand, we work towards building a resilient health system, which is a tall order.
Yes. See, I mean, you focus on urban. I think there's been these conversations moved to the urban. I think it's very important because what I've noticed is also the people who actually the working class in the urban area, a bulk of them are also single in the sense their families are out in the rural areas and they're here, alone, hoping to send back money back to home. And actually, it's a big dream for all of them to bring their families here. And I can see that those who brought their families here are a little more well settled than those who are still keeping them back. But what we've noticed also is they're now not able to send back more because they usually ate outside. They never cooked. And now with gas going up and inductions coming in, food prices have gone up. So, the urban conundrum will only break faster, will be a much bigger, play here, because of all what we are explaining. More importantly, you mentioned philanthropy. And what we saw is during COVID, there was a whole surge of philanthropy coming in and different people taking up many things. Obviously, this will not come. Any slow bleed, any slow thing will never attract, that kind of philanthropy. But what we did see was certain philanthropic houses like Azim Premji and all did decide at that time to actually go ahead and build hospitals and, equip them. They felt that was the most important thing. But if there's one thing we want to tell a philanthropist, imagine we have a waiting philanthropist to tell us what we need to do, what can we do, what would that message be to them? Where would they best, if you want to use the word invest, or put their money in. Neeta, and then anybody else who wants to come in from the audience.
I'll just give it a shot. I think the weakest link of our entire health system, and I'm focusing more on the health system. I know food and fuel and other things become much more important in the larger landscape. On the health system is the supply chain. I mean, while infrastructure is required, but when we talk of primary healthcare, which is foundational, supply chain becomes critical. So can we then convince philanthropic capital to sort of look at some of the supply chain solutions, which are quite attractive, right? I mean, if you look at newer technologies in supply chain, is that something that they would want to support? And also, as Reji mentioned earlier, local manufacturing, what further incentives could be provided. I'm not sure if philanthropists would be, willing to look at that aspect. That's largely seen as the government domain.
Anybody else would want to come in here or bring something different and new? Reji, I know you're from a different field where you're looking at the larger, very, very, very distant issues, that impact this. But I'm just thinking, what are your thoughts around, what we are discussing? Reji, you're on mute if you'd want to.
Yeah. See, you were discussing about safety nets. Okay, so let me share my reflections on that. See, we know the cost of medicines is there are different components of healthcare spending. So cost of medicines is the item on which the highest spending is incurred. And we also know that the health financing is driven by out-of-pocket expenditure. And if you look at the rural-urban divide, the share of medicines in the total health expenditure is much more in rural areas as compared to urban areas. Okay. So given this context, what I would propose is that government should use all its policy levers or regulatory levers. On the one hand, it has to keep the industry incentivized so that the production happens. At the same time, it should also take care that the price of medicines do not go up, exorbitantly. Okay, if the price of medicines goes up, then it will have a direct implication on out-of-pocket spending, and then that will in turn lead to more people going into poverty. So my proposal would be, already government has reduced the customs duty for the petrochemical inputs. So that is one policy lever the government has adopted. Similarly, it should explore whatever regulatory lever it can exercise to keep the prices of medicines at a reasonable level. At the same time, the industry is able to continue manufacturing.
No, thanks, Reji. We were actually expecting Dr. Mano Ragnani to come in here and give his closing remarks, and this would have been the time for him to do it, and we would close. But what I would like is for each one of our panelists to come in with their closing thoughts, a line before we close. And I'd ask, and I'm just taking the liberty of asking Yogesh Jain to also add his thoughts, before we close, and then we do our vote of thanks.
I think he's not here, is he?
Oh, has he also?
I think he's left.
Okay, that's fine then. I also did
Yogesh,
see
are you there?
Kunal. I also saw Kunal unmute himself. Kunal, did you have a question? Okay.
I think just
So-
talking of safety nets, I just wanted to add that some of the states which have in cities, which have the government-sponsored kitchens, like Amma Kitchen. I think there's one in some Rasoi in Delhi. I think those are a real, for many people, it's a good safety net for, working people like those who eat outside because they, migrants, urban migrants. This would be, if the quality was kept up and it was continued, I think that would be a real, like a soup kitchen, literally, but in the coming months.
Thanks. I think what we're saying is this is going to be a pinch or something like a tight situation, and it'll be the vulnerable that will become, will be impacted the most. We need to make sure that they have whatever it requires to do it, access to medicines, access to food, and access to work. Yes, and kitchens are a most important things, and I've really seen this work. I was part of a drive to make sure that in Jharkhand we did have these kitchens, and I did see, huge difference to what that happened. Avinash, you want to go in next?
So, I know it has a bad name, Reverie, etc. But over last 2-3 years or 5 years, the cash transfer to women and generally households have increased manyfold. This is a time to keep track of it. It may or may not be a reverie during good times, but right now it could be helpful. And we should track if the governments don't start delaying payments, etc., that they have committed to during election. And many states are even giving. And if you someone talked about fragmentation across schemes, but if you pool, for example, in Karnataka, it's about 55,000 a year per household. That's not huge amount, but it's not nothing either. Several states have done it. That would be one of the things that I would say. The second is that every crisis is an opportunity. These crises, it seems, have becoming more frequent, man-made and natural. So it's also a time to raise issue, make noises about long-term investments in health system, public safety net systems, in drug cases, more indigenization, etc. We are not in the globalized era, etc. So those kind of investments, long-term planning, we should start putting pressure to our government, state and federal to make there, because who knows where the next crisis is. It might be right around the corner. I'll stop there. Thank you.
Thanks, Avinash. Neeta?
Yeah, just had one thought in terms of, when we work with the government, can we try out something like a conflict scenario stress test kind of a system within our planning system, where we actually model that, if there is a disruption in supply chain, if there is a war-like scenario, how are we going to manage with our existing supplies? How are we going to manage, ensure that there are finance, there is infrastructure, there are, HR supplies that continue for ongoing services. So if we have to look at the Indian framework, we have the state PIPs. Can we do something at that level where we have something like a what if kind of a simulation model, where we try out we have different assumptions and test it out, just like disaster management or, how the military planning happens. I think it's high time we start looking at it differently rather than the typical PIP target, infrastructure, HR, and, budget kind of a system. Thanks.
Thanks.
Neeta, don't you think the pie is already so small that a buffer is hardly possible? Even with this, you're sort of stretching it and barely not managing to cover all the aspects that need to be covered. So
absolutely, but I think even the thought process.
Yeah,
for
the
instance,
planning
lot of states, lot of local governments, they say we don't have any dearth of resources. So if that's the case, then can you plan it for a resilient system? So maybe try to push the envelope there. I'm thinking more of from the public financing perspective. Obviously, on the other side, it's working with the communities towards saving better, towards making that rational, choice between having, the market driven fried food or whatever versus, nutritional food that is available locally. And again, it's more about rural population rather than urban, because urban really don't have even access to good nutritional diets. So those are the possibilities, but I was thinking more from the government perspective.
Yeah, probably involving also the panchayats and the resources they have.
Exactly. The urban municipal corporations and municipal councils, while they don't have a lot of resources, but whatever envelope they have, can they rationalize and plan it well?
Yes, I think
If
I
I
think it
can,
all. Go ahead,
sorry,
please.
if I can add one more point is also to repurpose whatever we invested for COVID pandemic. Rather than, I know a lot of them have become defunct, some of them have been repurposed. Can we, sort of use them for real-time monitoring of drugs and medical supplies and HR, sort of lot of technology, whether it was COVID, Arogya Setu, Abha, everything that has been created, can we sort of, up it and utilize it better? Sorry, Dr. Suranjeen.
No, not at all. And I think the key here is having responsive governance and government that is very sensitive to the needs of the people and really gets it. And I think the community that we are in, I think, has the moral imperative to advocate and to keep a track and make sure that this happens. I'd like to thank everyone here, especially the panelists for coming in and spending time here. Thanks a lot. It was really interesting for me, and I'm sure others benefited too. We also like to thank Shamsundar and team for hosting us here. Ramani, over to you for closing remarks, and then we can call this a day.
I thought you were giving the closing remarks.
No, that was my closing remarks, but just thanking the host for allowing us, to present this here.
Yeah. No, I think it was. I think this is something we all are sort of aware of, that this is approaching. It's like Avinash has said, this is going to be a kind of slow squeeze, a chronic kind of thing which will creep up on us. It's not that tomorrow the markets will be empty. But I think safety nets are extremely important, whether it is PDS, ICDS food, widening the range of things under PDS, urban kitchens, and for us involved directly in health, keeping a watch on our public systems of which of these crucial drugs are stocked out, and can we provide the buffer? Like if we have people we work with who are taking medicines from the government system and they're not able to get, can we bridge the gap? As a temporary measure. Those of us who also work with health determinants, yes, we have in Chhattisgarh, many have started, encouraging the community to shift to millets. But because MSP is now currently for rice and wheat, the reluctance of switching to millets, because it is also a source of income, apart from, the rice growing is also what fetches them money. So there are a whole lot of many dynamics, but I think with the water stress, it'll be easier if for them to switch to make the switch to millets and less water intensive crops, and also trying to be locally self-sufficient. Water will be a huge issue is what I'm thinking also. And what happens if we are really stressed for petroleum and other things? Are we going to be running the same number of buses, the same number of trains? Are the costs going to shoot up? Like Chhattisgarh and Jharkhand, they don't have public transport. So entirely dependent on private transport. So that I can see is already going to get expensive. So even just physical access to a health center is going to be a challenge. So there are multiple things, but I think it was a very useful discussion. The perspectives from food and from the budgets, fiscal space, and also the drugs and the potential, and where the problems are already existing and where they are anticipated. I hope this gives the group an idea of the sort of things we are looking at, a lot of which also depends on the duration of the conflict and as well as the super El Nino that we are facing this year. Yeah, I'd also like to thank Shyam and Arpita and all for giving us this forum, Exchanges in Primary Care. This discussion will be up on YouTube. So if you want to look at it or later, it will be called under Exchanges in Primary Care, then you'll get the link for it. I think Shyam is not here. And Arpita had said that she's got another meeting.
No,
I think probably Arpita.
Oh, you come back. Oh, good.
Yes. Yeah, thank you, everyone. Thank you for the discussion. And we'll share the recording with everybody.
Okay.
Okay.
Thank you
Bye-bye.
all.
Bye.
Thank you.
Thanks a
Take
lot.
care.
Bye.
Thank you.
Take care.
Bye-bye.